Good afternoon, everybody, and thank you so much for joining us for another one of our MAG specialist seminars. Today, we have the very wonderful Mr. Stewart Hayes, who is a podiatrist. He has many years' experience and all aspects of podiatry, but particularly sports podiatry, biomechanics, I can never say that word properly, biomechanics, footwear and orthotic therapy. He has significant experience in reporting in the medico-legal context, and his focus is on what is really necessary, what is appropriate, and what is the right thing for the injured worker. He has a number of memberships on boards and he's actively involved in his profession. He's a pretty impressive guy, and I have looked through this seminar before and I can tell you it's really going to be interesting. So can I ask that everybody please remain on mute throughout the session, just so that noise from your home or office doesn't interfere with the quality of the recording. And then at the end of the session, there will be the opportunity for you to ask some questions. If you have to go before the session's finished, you can always type your questions in the chat and I'll make sure that they get read out and answered at the end of the session. You will receive the recording of the session possibly Monday, but maybe this afternoon. And of course, the recording and all of our other sessions are saved to our YouTube channel as well. Without further ado, I hand over to you, Stewart Hayes. Thank you again so much for giving us your time and your expertise.
Thanks, Michelle. Welcome, everybody. Firstly, I'd like to wish to acknowledge the traditional custodians of the land through which throughout Australia, pay my respects to the elders, past and present, and extend that respect to Aboriginal and Torres Strait Islanders people today. I'll just go a bit of a background about myself. So I am pretty old school. I started doing podiatry when it was a 3-year diploma at TAFE. New South Wales was the last state to actually become a degree course, so I did it a long time ago. So I started work in a sports medicine centre where I've worked with team doctors for the Rugby Union, Australian Rugby Union, Australian Rugby League, New South Wales, team physios, that type of stuff. So surrounded with really great people who I picked their brains and learned from them. My focus is, as Michelle said, on biomechanics, orthotics, footwear injuries, workplace injuries, third-party medico-legal matters. However, I also do general podiatry. I've dealt with high-risk patients, diabetics. It's not my field that I really like to do, but I still dabble in it a bit. I've got 3 kids, so we'll still be working for a long time. They're quite young. And next year I do start a law diploma to increase my knowledge around the medico-legal sphere. Podiatrists, a lot of people don't know what podiatrists are. They often get called chiropodists. You can have a read through this. Basically, pod or pos means foot and iatros is a physician. So I often get little old Greek ladies calling me doctor, 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 because they understand that trist means physician or learned person. I don't use the title doctor. There are lots of podiatrists who use that. I don't like to confuse the public or my patients. So I tend to just keep it, people just call me Stewart. Now, overall, podiatrists do everything from cutting toenails, calluses, corns, warts, cracked skin, all that. We are all trained to do it. And it's stuff that I do on a Monday. I do general podiatry on a Monday. Podiatrists also look after high-risk patients, ones who have impaired circulation and sensation. We deal with wounds, ulcers, nail surgery, that type of work. Also, we do more the sporting side. So we have foot and leg injuries, strapping, exercises, shockwave therapy. You might have had that yourself, or something like plantar fasciitis. There's also foot mobilizations, which is akin to chiropractic for the feet. And we do gait retraining. Biomechanical assessments is where we look at the way people's feet work during gait, so when they're walking, and is there an underlying cause as to their leg injury or their foot injury or even their knee and even up to their lower back. I'll talk a bit off to the side here. Pronation is where a foot rolls inwards. Supination is where a foot rolls outwards. So just to, if I do refer to those things, that's what it's about. We also look at orthotics. I'll show you, there's orthotics here, some bend and flex, some that I don't like and I don't use, that are rock hard. And then there's other ones that are really flexible and they bend all over the place. There's a variety and many different podiatrists do many different things. We also look at footwear, good shoes and bad shoes. I will go more into that later. And what else? Oh, I've lost my screen. No, back on. So that's pretty much what podiatrists do. Now, in the sphere of workplace injuries and when is a podiatrist needed? A lot of the time, a case manager will not know when to get a podiatrist involved. And a lot of the time, we can help if somebody has a injury pretty much up to their lower back. If every time the person stands, walks or runs, they get discomfort in their feet or legs, we may be beneficial in that, because sometimes the foot is the underlying issue, then it's not addressed. Now, I'm a very big believer in pointing out the facts to the patient, whether it be a claimant when they're in front of me, that sometimes a similar or same condition would have occurred at the same stage of their life, something like plantar fasciitis, regardless of their employment. So we start to get into grey, but then there are other times where I say, no, this is definitely related to someone's employment. So it's never black or white. There's always a grey area at the moment. And it's because we do have an aging population. God, I'll be working till I'm well into my 70s because my kids are young. And people are bigger than they used to be. We're living longer. So we do develop wear and tear issues, a lot more related to our employment. People who stand a lot on hard floors, concrete, train station platforms, I'll talk about that later as well, can end up with things like plantar fasciitis or heel spurs. And it can be difficult to work out which one is related to work and which one is not. Work duties make and if somebody has to stand all day, play a big factor. So train station attendants, policemen, what else? Factory floor workers on concrete, those type of things have a big impact. Also footwear. I'll jump into this now. There are lots of people out there going to the shops and buying a pair of black work shoes because their job says you have to wear black enclosed shoes, but they get a shoe that is totally collapsible because it's really soft and squishy, and as soon as they put it on, it feels good. But then 3 weeks later, they got sore knees and they got sore back and everything. And it would have been a lot better if they had bought a shoe that was more stable and more sturdy, and they probably wouldn't have that workplace issue if they just knew what shoes to buy. Then there are also other factors that impact whether the matter. So some people have flat feet where the actual arch is lower. I don't want to break broken this many times. And then there's people who have increasing, so they have a high arch in their foot. And then there's also people who are, as we get older, stuff starts to wear out. And we also have people who have an increase in body mass, which does have an impact on foot integrity, because if there is too much load above, the foot does collapse. And it can also impact on knee arthritis and hip arthritis, those type of situations. Types of podiatry treatment, I've already spoken quickly about general foot care. Now, in an ongoing basis, if somebody dropped a brick on their foot at work or whatever, and they've damaged their nails and they're going to need ongoing care, it is typically every 4 to 8 weeks that they're going to need to have that care, and it would be indefinite. Sometimes if it's a high-risk person, it can be more frequent, but it's not something that I really see a lot of in the medico-legal sphere or the workplace sphere. Now, surgery, if that is if that person had a big injury at work and they required now surgery, that stuff is pretty much done once and it shouldn't be needed again. So there's no real ongoing care for that one. Exercise prescription is something that we do. So we show people how to stretch their calves and how to strengthen their muscles. Now, that can help in getting people back to a workplace situation. But the hard part is compliance. I find that very few people do what you teach them, or they do it at a poor level and they last for a couple of weeks and then they stop doing it. Now, if a podiatrist was to recommend exercise classes or routine consultation with their patients, I would recommend they do it 1 a week or 2 a week for 4 weeks, and then they need to review to see if the person's actually getting benefit. I'll talk now about shockwave therapy. That is beneficial. So if somebody recommends that for their claimant, that is beneficial for situations like plantar fasciitis. Now, plantar fasciitis is a condition that occurs with the arch muscle. It sets up an inflammation in this part of the heel, and it is the cause of heel spurs. Heel spurs do not cause plantar fasciitis. Plantar fasciitis causes heel spurs. And it is a condition that can occur regardless of employment. However, plantar fasciitis is more prevalent in those load-bearing occupations, as I previously said. Now, shockwave, I know that I've seen some reports or requests where the podiatrist has requested 10 treatments of shockwave over the next 1 a week over the next 10 weeks. Do 4. Don't approve 10. 10 is a long time. People will either get a result or no result and know where they're at after 4 weeks. So review after then. I would not be recommending any more than that. What else? Next one. Okay, more podiatry treatment. So custom-made orthotics, the big one, the most common one that I tend to see. I have no issue if somebody has a condition that is deemed to be associated with their work, that they get a pair of orthotics for their work shoes and they get a pair of orthotics for their home shoes, whether that be sports or casual or a dress shoe or whatever. 2 pairs is fine, and they should last anywhere between 1 and 4 years, depending on the materials used. Now, all orthotics are made out of a variety of materials. That's thick plastic. That one's a bit more flexible. I've already shown you the other ones. This one bends. This one doesn't. So that's going to last for a decade. Orthotics should wear out. They shouldn't last forever because then the person wears out. Something has to be consumable. Something has to wear out. I am of the opinion that orthotics should last around the 3, 4, 5 year mark, which means the person is getting, and the insurer is getting good value for money on that. If you have questions about how long the podiatrist who's asking for these orthotics, how long they estimate them to last, by all means, ask them, because then you're going to know, oh, well, why are we getting another one back and giving them more orthotics in 6 months and those type of things. There is a matter that I'll talk about later where somebody got 3 pairs of orthotics within a year, all to replace the previous one. So, yeah, you just need a bit more knowledge, and knowledge is power, so that if you ask the right questions, then you know that this claim will have a better outcome in the longer term, both financially for the insurer, but also for the patient. Reviews. A review after you give somebody a pair of orthotics should be in between 3 and 6 weeks. Now, it should be 1 to 3 reviews. Reason being, if there's any more or they're ongoing reviews, are the orthotics the right ones? Did the podiatrist give the right type? Were the podiatrist skills up to the level that they should be? They're all questions that you pretty much can ask. Now, the next thing that I see people requesting is extra depth footwear, just to fit a pair of orthotics. These orthotics fit into any shoe that is a lace-up shoe, like a jogger, a work shoe. They will not fit into a heeled shoe or a dainty female footwear shoe. This type of thing will, but proper orthotics where you take the insole out of the shoe and you put an orthotic in, that they should not require extra depth shoes. So the only reason why somebody would need an extra depth shoe is if they have got a arthritic foot or a deformed foot. So they've got arthritis in through their foot and they need a deeper shoe, so the shoe is actually higher in through this midsection. If the patient doesn't have that, then don't approve extra depth footwear. I will get to custom made in a second. Now, everyday shoes. Sometimes I see that insurers are buying people pairs of joggers, or they're saying, no, we shouldn't be buying pairs of joggers. It is a grey area. Okay, I'm sorry. If somebody leads a sedentary work, has a sedentary work situation, let's say an accountant sits down most of the time, I would not be saying, and that person tripped over and hurt their foot, I would be saying that no, the insurer should not really pay for a new pair of shoes if they needed to buy a new pair of shoes. However, if somebody injures themselves at work and they are on their feet all day, I'm okay with saying, okay, this person needs to buy this type of shoe. The insurer pays for one pair, and then after that, it should be at the worker's expense. Reason being, it's either somebody buys an Asics or a Brooks, or they buy a Hoka, they're still going to spend a couple of $100, getting up to $300 now, it's getting ridiculous, for the shoes. They're going to need to buy them regardless of their job. So if the insurer was to go, okay, here's the one that you need for your injury, everything after that is your own expense, I pretty much say that quite a bit in my reports. What else? However, sometimes when somebody does require a more expensive shoe, again, I will say at the insurer to buy that one, because it is sometimes the expense as well. But then the rest falls on the employee or the claimant. Now, the questionable stuff, where a lot of the time I see people where a request has been made for custom-made shoes, and this is a fact. Next week, I've been a podiatrist, or in 2 weeks, I've been a podiatrist for 29 years. I can remember prescribing 3 pairs of custom-made shoes. That's it. Where I've said to those people, you need to go and see a bootmaker, and the bootmaker will make you the shoes. Podiatrists do not make custom-made shoes. So if you've got an invoice or a quote for them, question it. And I'm serious, question it. Because when I have had some claimants where I've been doing an independent review, I've said to the claimant, okay, can you please send me or bring your shoes in, or send me photos of the shoes that are at home, because they didn't bring them in. Those shoes are not custom made, but the insurer has been billed for custom made shoes. They are store-bought shoes, or they are extra depth shoes that have been incorrectly invoiced as custom made with a price tag of over $1,000, and the shoes were probably worth $300. Okay, so yeah, be more questioning of the need for custom made shoes. Foot mobilizations. Foot mobilizations is, as I say here in the slide, it's akin to chiropractic. So it's mobilizing the feet. And what it does, it frees up a joint that can be a little bit stiff. It's just like having your back cracked or cracking your knuckles, those type of things. It feels good for that day. It feels good for the next day. And in an ongoing basis, it doesn't create a situation where the claimant becomes free of healthcare. They start to depend on healthcare. And under the CIRA clinical framework, the goal is to decrease the amount of healthcare that the claimant needs, not increase. So I rarely recommend any or approve any foot mobilizations. It would only be in an extreme circumstance where somebody may benefit from it, like they might have an adhesion or a joint that's limited, and just see. But again, I would only recommend 5 because I see in the reports that are requested from me, please approve 10. Please approve 10. No, go back to the 4 and 5 mark. Massage, yep. I see that podiatrists often recommend deep tissue massage for the plantar fascia or calf muscles. By all means, that can be beneficial, but again, similar things, it can have a short-term benefit. It's a much more longer term than the foot mobilizations, but you're going to get better value for money and better level of care from a qualified massage therapist. So that would be, outsource it to a massage therapist that you've worked with before or somebody recommended in the area. Proprioceptive training. Basically teaching people to have better balance. Questionable benefit, especially when, again, people are requesting 8 to 10 sessions. It's basically learning how to balance, learning how to walk again. If you're getting reports that have requests for this, I've never done it. Never needed to get somebody to stand on one leg and touch their nose and get better balance. Doesn't really work like that. Complex reporting. One of my bugbears. As you can tell, I talk a lot. I put things in simple terms. A good report allows the untrained reader to understand complex problems regarding the patient. There are plenty of podiatrists and health professionals in general, and I've read some from surgeons and specialists, that they love to use big words and jargon phrases that basically show how smart they are. And they befuddle the reader, okay? If you don't understand the report, you have a right to request that is written in plain English. Oh, I spelled plain English wrong. I spelled plain wrong. And don't pay for it till it's done. There's actually a clause in the Code of Conduct sitting on my desk over there that says it's about effective communication, and that includes to the insurer as well. You have to understand what is being recommended, and if you don't, re-request another report. As I've said a couple of times in this talk already, questionable care, excessive recommendations, 10 treatments. If you think that's too much, because 10 treatments is a long time, that's 10 months, that's 2.5 months. Approve 4 or 5. If you've approved custom-made shoes, ask the podiatrist first and foremost who is going to be making those custom-made shoes, who is going to be providing them, and once they have provided them, you need to ask for photos of them to prove that they are custom-made. I'm going to just jump out of this screen for a second and go to a photo. Here we are here. That one. There. These are, as you can see on this screen, the Dr. Comfort shoes. They are extra depth footwear that are appropriate.
We can't see that image, Stuart.
You can't see them?
Can't see it.
Okay. How do I do that then?
Maybe if you minimize your
okay, I'll do
presentation
that.
with the little minus sign.
Yep, I'll do that. Sorry. Should have practiced this first. Okay, what about there? No?
No, unless you share the screen, possibly.
Yeah, it's actually just an image.
Oh.
Size slideshow. No, it's not going to work. Okay, it's basically, I'll go back to the other one. Okay, it was basically a shoe that has the name written on top there. And if you see any name or you see any logo or any information on the inside of the shoe, it is not custom made. Custom made cobblers, bootmakers, podorthists do not have labels on the inside of their shoes. Okay. Also, there's another little thing that they don't have. It's little bleed lines. So they don't have soles where you will see that there's little bits of joins and those type of things. So all the custom made footwear that you'll always see, it looks unusual. So yeah, just to give you some information there. What else? Now I'll just go into a few case studies to talk about when I have ones that I've seen over the years. So it was actually about 6 months after COVID started, no, even longer, it could have been 18 months later. In about a 6-week period, I had 3 ladies come to see me who all worked for State Rail, and some bright spark decided to remove all the stools out of the booths on the train station. So they had to stand up and walk on concrete for 85 to 90% of their shifts. And they all developed plantar fasciitis. If anyone was to Google plantar fasciitis or Google policeman's heel, that's the old name for plantar fasciitis. And it's where the old coppers used to walk the beat in really hard boots and they'd get the heel pain. So that was definitely attributed, even though these ladies were in the classic age demographic and body type to develop plantar fasciitis, the change in their role meant that it was directly attributed to their work. And I did have to actually, part of the report was increase sitting time as part of the treatment. Now, on the other side, saw a 170 centimetre male, so not too tall, but he was 135 kilos, had flat feet, and has worn orthotics for 19 years. Happened to be walking at work and just twisted his body and felt a sharp pain in his heel. Went to his podiatrist, and the podiatrist requested that the insurer pay for his new pair of orthotics. And the insurer went, wait a minute, he's got a history of these. What's going on? So I basically had to state it was going to occur at some point that he was going to need a new pair of orthotics. And just because the action occurred at work didn't mean that work was liable. It was just him twisting his body. So just because an injury occurs at work doesn't mean work was the cause. Back to podiatrist supplied 3 pairs of so-called custom-made shoes to a claimant each year for 9 years. And that is the one that I tried to show you. This totaled thousands, and I'm talking tens and thousands of dollars. And I asked for the photos of the shoes, and that's what I tried to show you. And it was basically now the claimant has been advised to go and see a different podiatrist because the insurer no longer wants to work with that podiatrist. Yeah, because that's fraud, in my opinion. You can't bill for custom and provide ready-made. Just no other way to describe it. There was another time a podiatrist has invoiced the insurer for 3 pairs of custom-made orthotics and custom-made shoes in less than 1 year. I again asked the claimant for photos and actually got a response back, oh no, I had to buy my own shoes. Okay, so didn't even provide anything. And I only got 1 pair of orthotics. So these are the bad situations. Not all podiatrists are like this, so because the last one that I'm going to talk about is correct. Yeah, so in the last situation that I'm talking about, a podiatrist basically recommended that a claimant buy a pair of new shoes, Hoka, which is a shoe that's got a much thicker sole than a standard jogger, and they're thicker all the way in through here for work. And the complaint was actually lower back pain. And I approved that because being in that shoe would actually help the pain. It wasn't because it was a injury to the feet that required this shoe. It was actually part of the treatment to try and get the patient better and to decrease the back pain. Hoka are making really good shoes at the moment where they roll the person into the next step. They take a lot of strain out of the feet and the legs and the lower back. And it is something that people will start to get into more of them as they start to get out of these really soft type of shoes. And it's not just Nike. Sorry, I'll have another one. Here's a New Balance one as well, and there it is there, been like that. So yeah, footwear's not what it used to be. Being a gentleman who used to run in his 20s a whole lot more, my shoes lasted longer in my 20s when I ran more than I do now in my 50s. Yeah, so I think that's about it. I think we're up to the point where you guys get to ask questions and fire them at me. I'm okay with that.
Awesome. Well, thank you so much. I personally learned a lot from that. I'm going to go home and bend my sneakers and see what happens.
I can give a bit more info on that if you want. Actually, I'm just going to get my screen back. Okay. Features that make up a good shoe. How do I get myself to look at myself?
The back arrow.
There it is. Now I've got it. Okay. Features that make up a good shoe. It should bend at the front through here. It should be fundamentally stable through the midsection. They should twist a little bit. Should have a solid heel cut. You should never be able to do that to a heel. Okay. And the insole should be removable, just in case you ever need to put something inside. And they should be cushioned with a little bit of shock absorption, but not totally marshmallow soft. If it is too soft, it's like walking through a big field of grass that it hasn't been mowed for 3 weeks. It's really thick and it's really tiresome. You actually want a shoe that is firm, like you run on firm grass that's been freshly mowed. You get shock absorption, but you get energy return. So it aids you in the next step. Soft shoes are actually making me busier. So Skechers and the really, really soft shoes that you can get out there are making podiatrists busier, physios busier.
Wow. Okay. I bet your kids have some decent shoes on.
I fight the battles I can win.
No frivolous shoes at your house. People, has anyone got a question that they would like to ask? You unmute yourself. Here we go. Right, what does that say? There are several types of devices advertised on the TV that are touted to relieve foot pain, etc. There we go. And miraculously, the person is able to go out for a walk. What is the efficacy of these devices, and are there any foot injuries or conditions that they would work for?
Okay, I don't know the specific device, but there are lots of times when people turn up in my office and they've bought something online, or they actually can buy them from cruise ships, ones that are pre-made from a cruise ship. So that, yeah, they sell them because people go on the cruise ship and all of a sudden they walk around the decks a whole lot more. They start to get foot pain. I wear pre-made orthotics myself. I don't wear custom made because my feet are middle of the road. Okay, most people have feet that pronate. If we stopped 100 people in the street, 90 of them would pronate. 90, and some would be slightly pronated, some would be excessively pronated, all the way in. The pre-made orthotics that are sold online or on the TV will suit that mild to moderate level of pronation, and they will hold the arches up and they will be beneficial for that person. If that person then goes, oh, I feel great, I'm going to start running, and all of a sudden their body's under more stress, they're probably going to have less benefit from them. It's kind of like this scenario. It's how much your feet pronate, magnified by your age, because say your wear and tear, magnified by the level of activity that you want to have. And think of your car tires. If your car tires are tilted inwards slightly and you drive the car once a week on a Sunday, it's not a problem. But if you drive that car and you rack up 25,000 kilometres a year, it's going to be a problem. And then worn tyres will be the least of your problem. It'll be everything else that starts to go on the car. So your body's the same. So I wear pre-made orthotics because I'm a fairly mild to moderate, middle of the road foot pronation, and I play golf, I don't run anymore, and I walk my dog. That's it. So you can do it.
Okay.
Did I answer that question? Yes?
Yeah, sounds like. Anyone else have a question? No one's unmuting themselves. I beg your pardon. I do have a question, and it's actually from somebody who's unable to attend today. And it's in relation to good old high heels. You are not going to be able to stop women from wearing them, although I must admit at my age I have found that I can't do the heels I used to do. The question is, whilst people are not prescribed that they need to wear high heels, particularly in professional jobs, it's part of the suiting up and looking the part for the job. What are things that women can do to look after their feet when they are wearing high heels to work?
Don't go stiletto. So the really narrow point is very unstable. The broader block heel is a lot more stable. Try and go for a rounded toe rather than a really pointed toe. However, if you are going in to an important meeting and you want to be a bit taller, there might be some male you want to stand over because he's a little bit shorter and you want to be in the house, I'll go for it. I'm all for it. Then put the heels on, go into the meeting and sit down, and then get up and walk outside and take them off. Have a spare pair of shoes at work. Have the power heels at work under your desk, ready for those meetings or ready for those times where you need to be professional and be in that corporate wear. Nobody bats an eyelid in this day and age when you see somebody in a suit or a nice work outfit with a pair of joggers on, walking to work. That's fine. Go back 40 years ago, I'm sure it would have been, well, that person looks weird. But now, do that. So when you get there, change into the heels when you need to. Always take them off. You can have. It's just part of society, and if we could reprogram society, do away with heels, and women's feet would be a whole lot better.
One last question, and that is in relation to people who have a total or partial amputation of a toe.
Yep. What about it?
So how does a podiatrist help a person to be able to walk with stability and not do that clawing thing with your foot or not fall over?
Okay. In terms of levels of control and stability, 1 for the second, 1 for the third, 1 for the fourth, about 0.5 for the fifth, 2 for the first. So the first toe has double the control of the other ones. You can get by if your fifth toe gets amputated. Just the toe, not the metatarsal, not this part. So your finger, not this part. If it was your foot, you can get by. It's not really hugely important. But your first is your prime mover. So if it's that one, if people have lost that region there up into here, often you need to provide, and it's called, give me a moment. Okay, here we are. This is an orthotic it's what's called a Morton's extension. So having this under this point here, when this person walks, this artificially acts as the lever, because if you lose the big toe, you can't roll forward. What happens is your foot falls inwards because there's a void there now. So this is very engineering based. So your body mass is up here. So your pelvis and your other leg is in front. So all of your weight is at the front of your foot. You're about to lift your heel. If this toe isn't there, you fall inwards. And when you fall inwards, your knee rotates inwards. And when your knee rotates inwards, your pelvis tilts. So it can cause a whole lot of stuff. So just literally, this starts to occur. Just leaning in like that starts to occur because you've lost the big toe. So providing an orthotic that has a Morton's extension stabilizes that region, and these bend. It's not rigid, it does have to bend. So it gets the foot up and it springs the person into the next step. So that goes back to the shoes that I was talking about as well. If you've got a soft shoe, it doesn't spring you into the next step. The Hocker shoes have a curved forefoot, so it's a rocker sole. And if people look carefully here, this one here has a plastic piece in there as well. So there are some shoes that have plastic in through the front. So this person gets to here and the shoe goes, I'm not going to bend anymore, going to the next step. So that does have benefit for people who've had amputations. If somebody's lost the second or the third, then it would typically be an insole or an orthotic where you actually fill up that space. So you don't get the fourth and the first clawing, because that space will be filled, those toes will start to deviate sideways.
Wow.
That can be done.
Well, thank you so much, Stewart Hayes. That has
No
been
problem.
interesting, informative, and actually quite fascinating. I am going home to examine my shoes. Thank you, everybody, for taking the time to join us for the seminar today. We look forward to seeing you on our next seminars. And go forth, have a great afternoon, and enjoy your weekend. Oh, yes.
Thank you.
Thank you.